our audience to be able to care for patients that they think that may have primary immune deficiencies and learn how to work them up. So I'm going to hit the record button and get us started, and I am going to turn the floor over to Larry.
Great. Thank you, Angie. And thank you all for joining me this afternoon. Let me see if I can get my screen to work. And okay. Angie, nod your head if that looks okay.
Looks great.
Okay. To repeat what I said the last time I did one of these, I'm happy to be interrupted at any time. Otherwise, there'll certainly be time at the end for questions. I was assigned the talk of selective immunoglobulin isotype deficiency. Probably the key thing you need to know is there's really only a few bullet points about these IgA-M or IgG subclass. And I'm going to go through those very quickly in the first 5 minutes. The bullet points are in the slide collection. You are welcome to a copy of my slides at any time. I joke with the UVA medical students that at UVA, everybody's email address is the first and last initials of their name. So for me, that'd be LB. And the mnemonic for remembering my email address is that in the English language, L comes before M. So it's LB4M at virginia.edu. So if you do want a copy of these and get the bullet points, go for it. What I'm going to go for most of the talk is about the importance of the gut microbiome and the importance of that immune development and the risk for autoimmunity, other disease, and asthma. Basically, we're going to go on a wax poetic about the hygiene hypothesis. So really quickly, IgM deficiency, fairly common. These are just people who have a low IgM, and that is occurring in the context of a normal IgG and IgA. It's in the list from the Primary Immune Deficiency Foundation as an immune deficiency, but the clinical significance of an isolated low IgM is really not recognized, and most of these subjects are normal. My personal thinking is that IgM is, for lack of a better word, a speed bump. As you may remember from med school, IgM is the first antibody that gets made. It's low affinity. It doesn't do its job really well. So it's probably important in the first year of life, but once you have developed a good antibody repertoire by the time you're 4 or 5 years old, and you have IgG to most of the encapsulated encapsulated bacteria, IgG does a much better job, and just not having the IgM is not that big a deal. IgG subclasses, as you know, IgG comes in 4 colors, IgG 1 through 4. And the definition is that one or more of these is low, but your total IgG is normal. And it's really not accepted as any sort of an immune deficiency. As many as 20% of the healthy population have a subnormal level of one or more subclasses. People with subclass deficiency do not have any evidence for increased infection. There used to be this strong thought that you needed IgG1 and 3 for peptide antigens, things like tetanus or diphtheria. But what you needed for the bugs that cause sinus disease or ear infections or lung infections are these encapsulated bacteria like pneumococcus. And if you didn't have IgG2, then maybe you would be linked to recurrent sinusitis and pneumonia. But it turns out that if you have no IgG2, the other subclasses just are more than happy to step in. And it's just not an issue. So my takeaway message is that there is really never a reason to check IgG subclasses. All you need to know is the total IgG. And the only exception for that, of course, is if you're worried about IgG4-related disease, where obviously IgG4 could be very elevated. The last condition I'm going to talk about is IgA deficiency. This is actually considered the most common immune deficiency, and it occurs in North America at about 1 in 400 live births. The definition is an extremely low, basically absent, unmeasurable IgA in the face of a normal IgG and normal IgM. And key takeaway point, a slightly low IgA is not IgA deficiency. Nothing I'm about to talk about involves a person whose IgA is 35 milligrams per deciliter or something like that. This is for people who have no IgA. A slightly low IgA is really not associated with any kind of a problem. Again, most of these subjects are normal. Some of them have increased susceptibility to sinopulmonary and GI infections, especially Giardia. An obvious takeaway point is even if you have one of these patients who has horrible sinopulmonary disease and recurrent infections, we cannot treat them with IVIG because IVIG is just IgG. It doesn't fix the problem of the IgA deficiency. We can get into, if people have questions, how we can treat them either later or in a separate one of these sessions. These people do have increased prevalence of allergic diseases like asthma, atopic dermatitis. They also are at higher risk for numerous autoimmune diseases. The only real issue with IgA deficiency, again, that's absent IgA, not a low one, is transfusions, basically blood transfusion, because any blood product that you transfuse is going to have some IgA mixed in with it. And if you are born without IgA, your immune system will treat the transfused IgA as a foreign protein, and you will make an immune response to that IgA, which can be either IgE or IgG. Neither of those is good. If you make IgE, obviously you have potential for anaphylaxis, and even IgG is a problem because you'll make IgA immune complexes. They will activate complement, and then you'll get these complement products that can cause an anaphylaxis-like reaction, or you can get immune complex serum sickness type disease. So what we tell our patients with IgA deficiency is that they should only receive washed blood. I don't recommend medical alert bracelets. I hope that patients will be conscious at the time they get their blood transfusion. But even if they're not, the neat thing is the first transfusion is, if you will, free, meaning if you're unconscious, somebody gives you blood, we can test you after you got that blood to see if you did in fact make antibodies to IgA, and only the next time do we have to worry about it. This story may sound familiar because it's the same sort of thing we do with Rh mixed-matched mothers. The first one is free. So I don't think medical alert bracelets are warranted. We can monitor these people appropriately. So the rest of the talk, I'm going to talk about the fun of what happens with IgE deficiency. So as I said earlier, yes, they do get recurrent sinopulmonary and GI infections. That obviously makes sense. IgA is the secretory antibody. It's what is put into your sinopulmonary secretions. It's actually the most prevalent antibody made by a long shot if your gut is, and a healthy person is full of IgA. So it makes sense that if you don't have IgA, you're missing your first line of defense in your respiratory tract and intestine to these infections. But why more frequent allergies? Why does that make sense? And especially, why lupus, rheumatoid arthritis? Why are all these autoimmune diseases more prevalent in these folks?
Hey,
So,
Larry,
yep.
we have a question in the chat. I didn't want to interrupt you, but I don't want it to go unanswered. Dr. O'Donnell was asking, at what age would you normally diagnose the IgA deficiency, and would it change the breastfeeding as they get IgA through breast milk?
So the answer to the first question is we don't routinely check at all to see if someone has IgA deficiency. If somebody, there's certainly no age where you would routinely check. In the person with recurrent sinopulmonary infections, if you're having your second or third bacterial sinus infection, that is, as we've talked about in these sessions in the past, someone who you would be checking a humoral antibody screen. You would definitely want to know if they have low IgG, but we always check IgG and IgA at the same time. And that's where you're going to find that they're IgA deficient. The breast milk, that's actually a really interesting question. I have never heard of a case of a person who's IgA, a baby who is IgA deficient, making antibodies to mom's IgA. It's not strongly genetic, so that situation must happen all the time. And I think the argument, the best argument I could tell you is that the IgA in the breast milk is just not immunogenic. It may be passing, it does get passed down to the gut, but people just don't make, apparently these kids, if they do make antibodies to it, the antibodies are secreted into the intestines and it just doesn't cause a problem. But that's just not something I've ever seen. So I hope I answered your question. And Andrew, just keep, I'm not looking at the chat box. You'll just keep interrupting me if you
Gotcha.
need to. So I'm going to go off on a digression. This is just to remind you. So this whole concept of why somebody with IgA deficiency would have a much higher prevalence of lupus or rheumatoid arthritis. And the digression is to talk very quickly about Th17 cells and the rheumatoid arthritis mouse. Don't get lost in the weeds in what I'm about to talk about. What I want you to I'll tell you what I want you to walk away with, the big picture. But the big picture is that gut flora is really important to keep us healthy. So first of all, Th17 lymphocytes. The definition is these are your lymphocytes that produce the cytokine interleukin 17. And interleukin 17 does lots of useful things, like it activates all of these cell types that drive neutrophil recruitment. The bottom line from an immune viewpoint is Th17 cells are what you need to have an immune response to staph and candida. In a different session, we can talk about Th7. There's a lot of conditions where you have no Th17 cells, and they all have the combination of staph abscesses and chronic mucocutaneous candida, candida of the mouth, esophagus, and so forth. But the other thing you need Th17 cells that's bad is that they drive autoimmune diseases like rheumatoid arthritis and MS and inflammatory bowel disease. So this was a study from 1999, and I hate mouse studies. Mice teach us, I guess, a little bit about immunology, but there's almost nothing in there valuable for humans. But I'm going to go off on this tangent anyway. This was a mouse that was developed, as you see, in 1999 to study a version of rheumatoid arthritis. And these are mice that were reported to spontaneously develop a rheumatoid arthritis-like disease. And they made a mouse with a T cell receptor that recognized a self-antigen, not important what it was. And these T cells made B autoantibodies to B cells. And the beauty is you get pictures like this where within a few days of life, the mice would have thickened ankles and horrible arthritis everywhere. And it was pretty exciting because people thought it was a good model for studying rheumatoid arthritis. The problem was that while the science paper reported this wonderful model, all these follow-up studies showed that, hey, in our lab, these mice are perfectly healthy. They never get arthritis. So what the hey is that about? And this led to 10 or 11 years of trying to figure out why this rheumatoid arthritis couldn't be reproduced. And it turns out that the arthritis only developed in mice with what was termed a healthy gut microbiome. And in this graph, what you need to appreciate is germ-free. So these are mice that are sterile at birth and kept in a sterile environment. So they have no bacteria in their skin, lungs, whatever, but they have no bacteria in their gut. So these are germ-free mice. And the germ-free mice had no arthritis. The mice that got the arthritis had to have what was called specific pathogen-free, basically a healthy gut microbiome. So that was already interesting. Why do you have to have bacteria in your gut to get arthritis? And what was missing in the germ-free mice were these autoimmune causing Th17 cells. So again, you could do these kinds of studies as shown here, where on the left-hand side of this graph, you see in the healthy microbiome, that's the SPF mice, lots of Th17 cells, where in the absence of bacteria, in the sterile mice, no Th17 cells. So this obviously leads to the question, how do healthy microbes in the gut protect or cause arthritis? And in this case, the original studies from 1999 were mice that were grown, raised, and purchased from Taconic farms. And the Taconic farms mice fed Taconic farms chow had a normal complement of Th17 cells, and they got the arthritis. When the Jackson lab started raising these mice and started feeding them Jackson lab chow, none of the mice got arthritis. However, this is now 11 years later, you could show that the Jackson lab mice developed Th17 cells and could get arthritis when their intestines were given the bacteria from Tacoma lab mice, or for that matter, just housed in cages near the Tacoma lab mice, or it was all a function of the chow. Whatever the Taconic farm mice ate, they could develop it, and what the Jackson lab mice ate, they didn't get arthritis. So this led to these sorts of studies. Don't get lost in the weeds. They just have to question what is different in the gut of the Taconic farm and the Jackson lab mice. And it really came down to a single species of bacteria, something called Candidatus arthromatus, good name for it, arthromatus. And it's a bacteria that is, I'm going to use this abbreviation, it's a segmented filamentous bacteria. So there's a picture of what it looks like. It's ubiquitous in our intestines and in the Tacoma mice intestines, but not in the Jackson lab. It's shown in the bottom lab intestines. It's segmented, it's filamentous, it attaches to the epithelial walls and annoys the heck out of the immune system and promotes the function of Th17 cells. So if you don't have these bacteria in your intestine, you don't make Th17 cells. So forgive the long detour I just went into, but the takeaway message is a single bacterial species in the gut of these mice allows you to get the arthritis if you are a genetically susceptible mouse. So the model is that the Th17 cells, they're formed in the gut by the irritation of having this bacteria attach to the walls. The Th17s go to the draining lymph nodes, they go to the circulation, they populate other lymphoid organs where they become available to promote the autoimmune disease. And here's the takeaway message. The gut microbiome determines the initiation of an autoimmune non-gut disorder in a genetically susceptible host. The mice are what they eat, and how does this apply to humans? I'll come to that in a second. I'm not going to go into the same kind of long detour and bore you to tears with regulatory T cells, but again, you all remember these cells. These are cells that inhibit the function of antigen-presenting cells and effector T cells. They're basically responsible for immune tolerance to self. So if you don't have these cells, you get these autoimmune diseases like type 1 diabetes, rheumatoid arthritis, multiple sclerosis. And again, I could show the same long, boring slides, but specific gut microbiomes in the mouse, they're listed here, determines whether you make the Treg cells and whether you're susceptible to these non-gut autoimmune disorders. All right, let's go back to humans. These are data where I'm sure you're all aware. This is the explosion of allergic diseases like asthma. This is an old New England Journal study and just shows data from 20 or 30 countries, is showing how from 1965 to 2005, the prevalence of asthma is going up everywhere. And this is the same sort of thing now looking at food allergy. Food allergy used to be incredibly rare, but you can look at this is hospital admissions for a food allergy diagnosis. You can see like the quintupling of the rate over the 10 years from 1998 to 2006. So what is that all about? And that is what's led to what I think you're all familiar with, the so-called hygiene hypothesis, which can be summarized in one statement: filth is good. And that the lack of early childhood exposure to infections, bugs, parasites, whatever, is what's driving this increased susceptibility to allergic diseases. So I'm not going to go through every paper, but here's some aspects of hygiene that have been linked to asthma prevalence. Pet exposure, I'll show you that. Allergen exposure early in life, farm, unpasteurized milk, daycare, cesarean section, birth order. First birth is bad, second is, and later is good, water quality, breastfeeding. So here's just one really cool study. Let me just highlight, because otherwise this is kind of overwhelming. This is a European study. You can see the countries listed. And I'll just point out asthma diagnosis. So if you look at kids who were born on the farm, they're exposed to stables, they're drinking unpasteurized farm milk in their first year of life, then by the time they get to be 6 to 13 years old, 1% of them have an asthma diagnosis. Compare that to kids matched for age, gender, who had neither stables nor farm milk exposures, 12% asthma at the same time. This is a topic that is a positive skin test, 12% versus 33%. I mean, remarkable evidence for hygiene being bad. Pets in the home, this is my favorite protective thing. All these good parents who didn't want their children to have allergies and asthma, so they got rid of their dogs and cats, who in fact were doing the exact wrong thing. So just looking now at atopy, that's a positive skin test. These are American kids age 6 to 7, no dogs or cat when you're born. 33% of them are going to be allergic by that age, compared to 8% if you have 2 or more dogs in the home. Dogs really are your best friend. This is just looking at IgE concentrations, but I'm just trying to show you this is how many studies show stuff like this. If you have no cat or dog, by the time you're age 18, your IgE level will be over 100. If you were raised in a house with 2 or more cats or dogs, your IgE is almost half of that. So that has sort of led to, instead of calling it the hygiene hypothesis, it's better called the microbiota hypothesis, because all of these things can be linked to aspects of the gut microbiome. And that reads as follows: alterations in the gut microbial flora in early life. It's the gut microbial flora that determines the development of immune tolerance and autoimmune disease. So let's talk a little bit about the gut microbiome. It is the largest and earliest source of microbial exposure, obviously. Hundreds of trillions of species of organisms, of bugs total, from thousands of species. And basically, the way I tell this in my medical school lecture, your immune system basically practices in the first year of life. The one thing it's getting exposed to is these thousands of species of bugs in your gut. And that's where your immune system basically develops its repertoire. It develops the experience it's going to use later in life when it starts seeing pathogens. And the human immune system evolved millions of years ago, and it was genetically selected to function optimally in the environment and diet of our Neolithic ancestors. So there's this concept that it's the altered gut microbiome that's driving allergic diseases, inflammatory bowel disease, type 1 diabetes, metabolic syndrome, and basically all of the diseases that have become epidemic in our society. But the linkage of a neonatal gut microbiota to systemic immune disease is not obvious. That's why I went off on that tangent about the Jackson Lab Tacoma study, because it really points out a single bacteria in the gut can determine in a genetically susceptible mouse whether that mouse will get rheumatoid arthritis. But how does that link work? How does defective Treg development or altered Th17 effector development influence systemic immune response? And again, I'll repeat what I said. The immune system evolved and genetically selected to function in the environment and diet of our Neolithic ancestors. So is there a correlation? So I love this study because it's a study comparing European children, you see the ages here, who are on the developed world diet, compared to a rural village in Africa, an ethnic group that was thought to resemble, at best, the subsistence farmers of our Neolithic ancestors. And don't try to understand the slide. This is sort of what you get when you do a microbiome analysis. The different cultures, the different colors represent different species of bacteria in the gut. And you have the African data on the top and the European data on the bottom. And what you see is a microbiome that is comprehensively different in the Western diet. And that's not good for our immune systems. And the thing driving the Burkina Faso data is the high fiber intake and the great prevalence of bacteria capable of digesting fiber. So let me go back to what I began this section of the talk with, determinants of human gut flora, gut microbiome. Obviously, the first thing that determines a gut microbiome is mom. And there's a huge difference between whether you were delivered vaginally or by cesarean section, because that is really the first exposure that seeds the gut. Bacteria from the immediate environment, hand to mouth activities. Any of you who have worked with children, seen children have children, know that children will put whatever they find in their mouth instantly. Sigmund Freud came up with this oral fixation. I actually wonder if this concept of just putting all that dirt in your mouth is not, in fact, an evolutionarily ingrained behavior, because it's what the immune system is counting on to develop properly. And when we slap our kids and push them away from the dirt, whether we're actually doing them a huge disservice. Diet, breastfeeding versus formula, huge difference in the microbiome. Antibiotics, the statistics on how many days of antibiotics children have received in their first year of life, and that has a huge impact on the gut microbiome. But honestly, the most overwhelming data is the importance of exposure to indoor dogs. Facets of hygiene that can be linked to the gut microbiome. So here's that list again. You know, parents always ask me, when they have asthma, they both have asthma, what can we do to prevent our child from having asthma? I asked medical students, do you think I actually tell a parent what I'm about to tell you? And the answer, of course, is, of course I do. It says, when you have your baby and get a dog, watch the dog. And when you see the dog licking its butt, immediately put your baby next to that dog and have that dog lick your baby's face. Now, I do say that, I'm smiling when I say it, but it's not that far from the truth. What the dog is bringing in is not dog allergen. What the dog is bringing in is that rich microbiome that our immune system requires in the first year of life. So last little bit of this talk. This is a study published a couple years ago. It was looking at high-risk children. This is defined as mom or dad had asthma and was allergic. And they looked at the microbiome in the first few years of life, and then came back a few years later and say, hey, what was the risk of developing allergy and asthma in those children? And the neo-gut you see there's a very specific gut microbiome. This is that NGM3 on the right that really predicted having allergies or asthma. And these are log transformed data. So it's a highly risk gut microbiome. And I won't get into too many details. The bacteria in there make fatty acid products that promote Th2 cells from being made. They inhibit T regulatory cells from being made. And in point of fact, every doubling of the gene that makes these fatty acids in the feces was associated with increased odds of having eczema, asthma, or food allergy by the age of 2 or 3. So there's currently a study going on. It's called the IMPACT trial. It's basically trying to take these high-risk kids, put in the bacteria that we know are helpful in preventing the development of allergies and asthma. These kids are being given these bacteria within a few weeks of birth. And again, the high risk is 1 or more parents with asthma. And this result's going to be announced this spring. And a lot of us are really excited to see whether we can do this as an approach that can be used to prevent allergies and asthma. But in the meantime, tell your patients who are worried, get a dog, or even better, get 2 dogs. All right, so how does all this tie into IgA deficiency? I think this is the last slide. Remember, IgA deficiency is associated with higher than expected allergic diseases like asthma and autoimmune disease. So I don't know the connection, but the one thing I do know is that most of the IgA you make goes into the gut. It is the most important determinant of the gut microbiome. And if you don't have IgA, you definitely have a dysfunctional microbiome. And I do suspect that that's the connection. And I will stop there and gladly entertain questions if people have any. And I hope I didn't lose you too much in the weeds there of my Jackson Lab mouse, but I think it's really cool that a genetically susceptible mouse will only get arthritis if it eats the wrong thing, because God knows that genetically susceptible, it just fits the model that genetically susceptible humans, susceptible to things like asthma or autoimmune disease, the gut microbiome could determine their long-term health. So do we have any questions for me, Angie?
Dr. Wilson has a question.
Hi, sorry, I was having trouble trying to write this all out, so I figured I'd just say it. In a lot of those studies, it seemed like after a year or after 2 years old, no matter kind of what changes you make or what exposure they have, it doesn't really seem to make a difference in their IgA status, in their allergy and immune response status. Is there, I mean, I have a 3-year-old right now who they said, seems like she's inherited her mom's asthma and allergy, everything you're talking about with
Yep.
her being born in the height of COVID. I think that's probably why she's like so hypersensitized to everything. But what can she do now that, I mean, she's 3.5 years old already, and she's kind of past that point of early life exposure.
So just to be clear, I mean, none of the studies I showed were intervention studies. The only intervention study is the one I alluded to at the end, where these kids who are in the first 2 or 3 years, 2 or 3 weeks of life are given a healthy gut microbiome. The exception to that, of course, that you may be familiar with, the two exceptions to that. The big exception, is the peanut story. Um, for years, the American Academy of Pediatrics was telling at-risk parents, avoid peanuts. And then peanut allergy kept going up. Well, it says, that's, avoid peanuts while you're breastfeeding. And the prevalence of peanut allergy kept going up. And well, avoid peanuts when you're pregnant. And the prevalence of peanut allergy kept going up. And suddenly discovered, no, no, no. What the neonatal immune system needs is a lot of exposure to peanut. This is different from everything I just talked about. What this is a case of is early in life, the default function of the immune system is generally speaking tolerance. God, I could talk about this for half an hour, and it's already a couple minutes past 1. But the key thing is the newborn immune system defaults to tolerance. You have to work really hard to get a newborn to be responsive to vaccines, which is why vaccines so many of them get postponed to 6 months or a year. The immune system of a newborn wants to sense of view everything it sees as self or at least harmless and makes a regulatory response. So when a 6-month-old sees peanut, the default is to make regulatory T cells. And that's why all those new guidelines are pushing, no, 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 we're giving the exact wrong advice. Give peanuts. The cat story, and this is different from the dog story, there were these incredible studies that showed all the parents who thought they were doing the right thing by getting the cat out of the house. Those are the kids who get the cat allergy. If you're born in a house with cats, that early exposure basically tells the immune system, not a problem, ignore it, make regulatory T cells. So exposure to allergen early in life turns out to be a good thing for making regulatory T cells. The dog is a wholly different story. That's the microbiome story. So the earlier interventions, foods, yes. Cat, yes. COVID was interesting because there's so many things that went wrong with COVID, like all of the masking and avoidance we were doing. I'll go back to one of the things I listed but didn't talk about, daycare. Everyone thought, well, part of the problem with asthma is we're putting children in daycare and they're getting all these viral infections and that's what's driving it. Well, it turns out the kids in daycare had less asthma because, again, it's good for the immune system to have frequent infections and in order to develop appropriately. And the avoidance of infections and the use of antibiotics all turn out to be negative things. I'm sorry, I just threw a lot of stuff at you. You know my email address, by the way, lb4m at virginia.edu. So if you want to continue this conversation online, I'll be happy to do that. Were there any other questions?
All right, so we'll start wrapping everything up. I am going to send everyone an email out. The email is going to just ask for suggestions because a lot of you guys are attending frequently. We want to make sure that if you have a topic that you really want us to go over, we would be happy to do that. So expect an email from me. This will also be on our YouTube channel, and it will be and Larry's slides will be able to access later if you want to go back and look at something. And I do appreciate everybody coming and have a good day.
Thank you. Bye-bye.